Concept 23, immunity. The ability of the human body to sustain health within the environment requires multiple protective mechanisms. One of the most complex protective mechanisms is the immune response. When immune processes are functioning optimally, the body has the ability to mount an efficient defense in response to the invasion of foreign substances. Such a response is critical to maintaining health. It is reasonable then to conclude that multiple health problems occur in the absence of normal immune response. Although this concept presentation describes the concept of immunity from the perspective of both normal and abnormal functioning, the primary focus is on that of abnormal because of the multitude of health-related problems that result. Learning objectives. Define and describe the concept. Notice risk factors for altered immune functioning. Recognize when an individual has altered immune functioning. Provide appropriate nursing and collaborative interventions to optimize the immune response and to minimize the complications of an altered immune response. Immunity is commonly defined as a physiological process that provides an individual with protection or defense from disease. It's a characteristic that allows one to be resistant to a particular disease or condition. The term is derived from the Latin word immunus, meaning exempt. Immunity is accomplished through the actions of the immune system, which is a body-wide, complex, interrelated group of cells, tissues, and organs that work within a dynamic communication network to protect the body from attacks by foreign antigens, typically proteins. These foreign antigens may include microorganisms such as bacteria, viruses, parasites, or fungi, but they also may be proteins found in pollens, foods, bee, snake, or spider venom, vaccines, transfusions, and transplanted tissues. As noted previously, this concept includes abnormal function leading to health problems. For the purpose of this concept presentation, a broader definition of immunity is used: the normal physiological response to microorganisms and proteins, as well as conditions associated with an inadequate or excessive immune response. Additional terms are used to differentiate the type of immunity. Protection. Innate immunity is also referred to as natural or native, is the immunity present at birth. It provides nonspecific response not considered antigen-specific. Acquired immunity refers to immunity protection that is gained after birth, either actively or passively. Active acquired immunity develops after the introduction of foreign antigens, resulting in the formation of antibodies or sensitized T lymphocytes. For example, active immunity may be obtained artificially through the immune response to an immunization, or it may be obtained naturally through the immune response to exposure to infectious pathogens such as varicella zoster virus. Passive acquired immunity occurs by the introduction of preformed antibodies, either from an artificial route such as transfusion of immunoglobulin, which is abbreviated IG, or from a natural route such as from a mother to her fetus through placenta blood transference or through colostrum transfer during breastfeeding. Scope. The complexity of immunity often makes it difficult to fully understand from a traditional presentation. From a conceptual perspective, it is useful to think about what this concept represents from a very broad view and consider the context of patient-related issues. The scope of immunity and related immunity problems are described as optimal and abnormal. An optimal response represents an immune system that protects the body from the invasion of microorganisms, removes dead and damaged tissue and cells, and recognizes and removes cell mutations. Abnormal function includes a suppressed immune response and exaggerated immune response. To the far left of the immune response spectrum, see the figure above on the slide, is a hypo or suppressed immune response. Individuals who have suppressed immune responses are referred to as immunocompromised or are considered to be in a state of immunodeficiency. Individuals with suppressed immune responses are at significant risk for infection, or if immunosuppression occurs over time, they are at risk for cancer because of the loss or removal of mutating cells. To the far right of the immune response spectrum, again, picture 23.1, is a hyperimmune or exaggerated immune response. Hyperimmune responses range from allergic reactions, cytotoxic reactions, and autoimmune reactions. A critical component of the immune system is its ability to differentiate between self and non-self. When this recognition fails, the immune system may begin attacking host cells in an exaggerated immune response. This process leads to the development of autoimmune diseases and disorders. The immune response involves the following three primary protective functions. 1. Protects the body from invasion of microorganisms and other antigens. 2. Removes dead or damaged tissue and cells. 3. Recognizes and removes cell mutations that have demonstrated abnormal cell growth and development. To accomplish these functions, the immune system reacts with three lines of defense. The first line is the skin boundary surfaces, including mucous membranes, enzymes, natural microbial flora, and complement proteins. The second line of defense is accomplished by the activities of phagocytes, natural killer T cell lymphocytes, and granulocytes and macrophages, providing innate, nonspecific immunity. Finally, the third line of defense comes from antibodies derived from B lymphocytes and the T lymphocytes resulting from learned or acquired specific immunity. Recognition of the self and recognition of foreign proteins are the hallmarks of a properly functioning immune system. The individual must be able to differentiate between host and foreign proteins in order to respond appropriately. With the invasion of foreign proteins, a protective response is needed. Failure to respond appropriately, such as immunosuppression or immunodeficiency, results in infection or disease. Likewise, the body must maintain the ability to recognize host proteins and not initiate an immune response. When this recognition fails, the immune system launches an attack on host cells called autoimmune response or initiates a hyperactive immune response such as occurs in asthma, which is called a hyperimmune response. Major histocompatibility complex proteins, called MHC, proteins are divided into two classes, with class 1 being found on all cells and class 2 on specialized cells. MHC proteins function in part to differentiate cells of the self or the host from foreign proteins. Substances that are non-self are capable of initiating an immune response. A foreign antigen may be a whole cell, a virus, a bacterium, an MHC marker protein, or a small portion of a larger foreign protein. Epitopes are the markers on foreign antigens that cause the immune response in individuals. The MHC provides what has been termed a scaffold that presents the foreign antigen to the immune cells. The empty MHC scaffold, also termed a self-marker scaffold of a foreign cell from a donor organ, may be introduced into the host during a transplant. These MHC self-marker scaffolds are the individual's tissue type or human leukocyte antigen. Organs comprising the immune system. Organs of the immune system are spread throughout the body. They are termed lymphoid organs and include the bone marrow, thymus gland, spleen, tonsils, adenoids, and appendix. From these organs, the lymphocytes are formed, grow, mature, and released into the body. The body's lymphatic system provides the network by which organs of the immune system are connected. The blood also provides a connection among the organs and provides the route for lymphocyte movement throughout the body. Origins of cells in an immune response. A variety of components work together to provide an immune response. All cells in the immune system are derived from stem cells in the bone marrow and begin as either myeloid progenitor or lymphoid progenitor cells. Myeloid progenitors include neutrophils, monocytes, which become macrophages in body tissues, eosinophils, basophils, and mast cells. Lymphoid progenitor cells include B lymphocytes, which become plasma or memory B cells, mature T lymphocytes, and natural killer cells. B and T lymphocytes. During fetal development, B and T lymphocytes are produced in large numbers. All immune cells begin as immature stem cells in the bone marrow and grow into specific immune cell types such as B or T lymphocytes or phagocytes. Pre-processing and maturation of the B lymphocytes occur in the liver during mid-fetal life and in the bone marrow during late fetal life and after birth. Maturation of T lymphocytes occurs in the thymus gland. This process is called generation of clonal diversity. As a person is challenged by the presence of foreign antigens during life, specificity of lymphocytes to a more specific antigen emerges, a process termed clonal selection. On re-exposure to the same antigen, the person will have a more rapid and efficient immune response, indicating a memory capacity for the immune system. Antibody production. Antibodies are secreted by B lymphocytes. Antibodies or immunoglobulins are formed after a B lymphocyte encounters and engulfs an antigen and then interacts with helper T lymphocytes. The B lymphocytes then begin producing identical copies of a specific antibody. Researchers have identified 9 classes of antibodies or immunoglobulins, 4 forms of IgG, 2 forms of IgA, and 1 form each of IgE, IgM, and IgD. Immunoglobulins are found in various concentrations at different sites throughout the body. IgG, primary immunoglobulin in the blood, 80 to 85% of circulating immunoglobulins, may enter tissue spaces, selectively cross the placenta, coats antigen for more effective and efficient presentation for an immune response, binds to macrophages and neutrophils for increasing the phagocytosis. IgD is found within the cell membrane of beta lymphocytes. IgE is responsible for allergy symptoms and increase in the presence of parasitic worms normally found in trace amounts. IgA protects entrances to the body, found in high concentrations in body fluids such as tears, saliva, and secretions of the respiratory and GI tracts. IgM remains in the blood and efficiently kills bacteria, largest of the immunoglobulins, the first antibody produced with an initial primary immune response. Phagocytes. Phagocytes are found throughout the body and are usually responsible for recognizing and ingesting foreign antigens as they enter the body. Macrophages and neutrophils are the primary phagocytic cells, responsible for this first line of defense during an immune response. Macrophages are the primary defense cells against antigen entry to the body. When awaiting the need for phagocytic activity, large numbers of macrophages are stored in connective tissue, the spleen and liver, and the lining of the GI and respiratory tracts. Neutrophils remain circulating in the blood. Phagocytosis is the process of ingesting cellular material and involves the ability of phagocytes to be selective in recognizing cells that must be ingested and discarded. Healthy cells of the self tend to be smooth and covered with a smooth protein coat that normally functioning phagocytes tend to ignore. Antibody-antigen complexes have rougher surfaces and are particularly susceptible to phagocytic functioning. Although both neutrophils and macrophages are phagocytes, in an immune response, the macrophages are more effective than neutrophils. Complement system. The complement system works to enhance the immune response and to help rid the body of antibody-antigen complexes. The complement system is composed of 25 major proteins that circulate in an inactive form in the blood and are engaged in a cascade of interactions when the first protein molecule, called C1, encounters an antigen-antibody complex. The complement cascade is also responsible for the dilation and ultimate leaking of fluid from the vascular system, leading to the redness and swelling during the inflammatory process that are associated with an immune response. Lymphocyte function in an immune response. A general overview of immune system development and maturation is leading to an immune response to a foreign antigen is presented in Figure 23.2, page 220. Beta lymphocyte response. McCants and colleagues differentiate immunoglobulins as all molecules that have specificity to an antigen and an antibody as one particular set of immunoglobulins with specificity against a known antigen. Immunoglobulin or antibody is a glycoprotein produced by B lymphocyte plasma cells in response to the presentation of an antigen. Plasma cells are B lymphocytes that have differentiated into plasma cells and memory cells from exposure to an antigen. The major classes of immunoglobulins and the area of focus in an immune response have been previously identified. Immunoglobulins are primarily responsible for the body's response in invading bacteria and viruses and provide for the humoral immunity component of an immune response. T lymphocyte response. T lymphocytes undergo differentiation on exposure to a foreign antigen, developing into subtypes of cells that may directly attack the antigen or stimulate the activation of other leukocytes. Cytotoxic C lymphocytes attack and kill antigens directly with preference for viruses or mutated cells that have become cancerous. This type of innate immunity is termed cellular or cell-mediated immunity. Several types of T lymphocytes or T cells may be classified into three primary groups: helper T cells, cytotoxic T cells, and the suppressor T cells. Helper T cells, CD4 cells, comprise approximately 75% of all T lymphocytes. They help in the functions of the immune system by regulating most of the system's function via the protein mediators called lymphokines. They help direct and encourage other T cells and also help to activate B lymphocytes. Cytotoxic T cells, also termed killer cells, directly kill foreign antigens and may kill cells of the self. Suppressor T cells suppress the function of both helper and cytotoxic T cells in order to prevent hyperimmune response. Complement system response. The 25 primary proteins of the complement system contribute to an immune response by amplifying and increasing the efficiency and efficacy of the other components of the immune system. The complement system also contributes to the inflammatory response. The primary activities resulting from activation of the complement cascade include increasing bacterial susceptibility to phagocytosis, lysing some types of bacteria and foreign antigens, producing chemotactic substances, increasing vascular permeability, and increasing smooth muscle contraction. Dendritic cells are potent cells in asserting control from initiation to termination of the immune response. Dendritic cells have a sentinel function throughout the body as they look for foreign antigens and alert lymphocytes to the presence of urine injury or infection. They are also considered antigen-presenting cells. They bind to antigens and then process and present them to both B and T lymphocytes in an immune response. They have been found to directly activate helper and killer T cells and present cancer cells to cytotoxic T cells, which respond by killing mutant cells. Problems associated with immunity may occur in individuals across the lifespan with a range of impact from minor symptoms such as a runny nose to life-threatening consequences. Variations may occur as a result of diminished or exaggerated immune functioning or responses to autoimmune situations in which the immune system is attacking the self. Suppressed immune response. An inadequately functioning immune system leaves the individual immunocompromised. Immunodeficiency is either classified as primary or secondary. An inadequately functioning immune system leaves the individual immunocompromised. Immunodeficiency is either classified as primary or secondary. Primary immunodeficiency is a situation in which the entire immune defense system is inadequate and the individual is missing some, if not all, of the components necessary for a complete immune response. The National Institutes of Health, NIH, has identified more than 70 different types of immunodeficiencies. 10 warning signs of primary immunodeficiency were also identified by the NIH, with primary immunodeficiency suspected if 2 or more of the signs are evident. The 10 warning signs include the following: 4 or more new ear infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months of taking antibiotics with little effect, 2 or more pneumonia within 1 year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infection on skin, the need for intravenous antibiotics to clear infections, 2 or more deep-seated infections including septicemia and a family history of primary immunodeficiency, Common variable immunodeficiency is one of the most prevalent PI diseases and is manifests with a deficit in antibody formation following a deficit in B lymphocytes that interferes with the ability of the cells to differentiate into plasma antibody producing cells. Secondary immunodeficiency is a loss of human functioning in a person with previously normal immune function as a result of an illness or treatment. A depressed immune system may be created with medication in order to avoid rejection of transplanted tissue, or it may be induced as a result of treatment for various types of cancer. In the treatment of some types of leukemia, destruction of the bone marrow is necessary before healthy stem cells may be reintroduced and a healthy immune system regrows. Throughout the treatment process, the immune system is partially destroyed, leaving the individual immunocompromised. Conversely, some cancers such as multiple myeloma, Hodgkin's disease, and non-Hodgkin's lymphoma may directly lead to immune system dysfunction and immunocompromise. This chart shows you exaggerated immune response. There's 4 types of exaggerated immune response. Type 1, which is IgE, type 2, which is cytotoxic, type 3 is immune complex mediated, and type 4 is cell mediated or delayed hypersensitivity. Hypersensitivity reactions include local effects and systemic effects. This exaggerated immune response will generally be classified as one of 4 classes of hypersensitivity disorders. Type 1, IgE mediated or atopic allergic reactions. Type 2, tissue-specific or cytotoxic. Type 3 is immune complex mediated, and type 4 is cell-mediated or delayed hypersensitivity. Hypersensitivity may be defined as an abnormal condition characterized by an exaggerated response of the immune system to an antigen. Hypersensitivity reaction is inappropriate and excessive. The pathology associated with hypersensitivity reactions is summarized in Table 23.1, page 221. Exaggerated immune response may be localized or they may affect all body systems. A bee sting may cause a localized type 1 allergic reaction, or it may cause a systemic anaphylactic reaction. Systemic anaphylactic reactions caused by a number of foreign antigens are also considered type 1 hypersensitivity reactions. Type 2 tissue-specific reactions may lead to myasthenia gravis, which is MS, hyperacute graft rejection with transplanted tissues, or autoimmune-based hemolytic anemias. Type 3 immune complex mediated responses are the basis for rheumatoid arthritis or systemic lupus erythematosus, which is abbreviated SLE or called lupus. Type 4 cell-mediated responses are seen with transplant rejection or poison ivy allergic responses. In cases of exaggerated immune response, the individual may be damaged or otherwise harmed by a response that is supposed to be protective or curative, as is seen in the presence of anaphylaxis. Autoimmune responses may result in the development of type 1 diabetes mellitus, lupus, or rheumatoid arthritis. Consequences of immunosuppression. A number of serious health problems develop for the immunocompromised individuals. Some problems include an increase in the incidence of infection by bacteria and viruses, the development of superinfections such as methicillin-resistant Staphylococcus aureus, or MRSA, or Clostridium difficile, which is C. difficile or C. diff, or the development of treatment-resistant fungal infections secondary to antibiotic treatment for primary bacterial infections. In situations in which a suppressed immune system is evident, the individual may not be able to mount a sufficient response to avoid or repair a diseased body organ or system. For example, cancer, particularly in the elderly, has been associated with an immunocompromised state and a diminished ability to recognize and destroy mutant cells. Consequences of an exaggerated immune system. Multisystem or single-system disease may result from an initiating hypersensitivity response. Cardiovascular diseases may emerge as a consequence of autoimmune disorders such as Graves' disease or lupus. Renal failure may result from chronic glomerulonephritis or polycystic kidney disease. HIV disease weakens the immune system, and a variety of opportunistic diseases and infections will ultimately result. Autoimmune disorders occur when the immune system attacks and destroys healthy cells following a breakdown of what has been termed self-tolerance. With more than 80 autoimmune disorders already identified, an individual may have more than one autoimmune disorders at the same time. This type of immune disorder is associated with three potential outcomes: destruction of one or more types of body tissues, abnormal organ growth, or changes in organ function. The degree of destruction and functional loss varies dramatically and depends on the type of immune disorder, age, overall physical and nutritional health, and treatment. Some of the more commonly occurring autoimmune diseases include rheumatoid arthritis, lupus, muscular sclerosis or MS, Graves' disease, and diabetes mellitus. Genetic predisposition is an important factor in the development of autoimmune diseases, with manifestations of the disease often associated with some type of environmental trigger, such as bacterial or viral infections, or physiologic or environmental stressors. Risk factors. People from all ages, socioeconomic, and racial ethnic groups can potentially have impaired immune systems. However, some population groups and individuals are at greater risk than others. Risk factors for suppressed and exaggerated immune function are presented separately in the following sections. Suppressed immune function. Age. In the very young, the immune system is immature with inadequate lymphocyte function, particularly T lymphocyte deficiency. Newborns rely on immune protection from the mother through placental blood transfer and from the high levels of immunoglobulin found in colostrum during breastfeeding. During the next few months, maternal antibodies are slowly destroyed, with the rate of catabolism exceeding the rate of newborn immunoglobulin production. This mild hypogammaglobulinemia contributes to the increased risk of infection in the newborn. In the elderly, loss of immune effectiveness occurs in part because of the physiological aging and shrinking of the thymus gland, leaving it at approximately 15% of its maximum size by middle age, and decreasing the ability of T lymphocytes to mature in the gland over time. Research has also demonstrated that elderly people have fewer T lymphocytes, produce fewer immunoglobulins, experience a delayed and diminished hypersensitivity response, and demonstrate an increase in autoantibodies. B lymphocyte function is diminished secondarily to a decrease in circulating memory cells that evolve after approximately 60 years of age. Non-immunized state. Individuals who are not immunized are susceptible to a number of infections, including rubella, measles, mumps, tetanus, diphtheria, and hepatitis. Many of these diseases can be fatal to the very young, the elderly, or those who are immunocompromised as a result of a disease process or their treatment, and other environmental factors. Environmental factors, such as poor nutrition, exposure to pollutants, including tobacco smoke, or heavy metals and other stressors, may depress immune functioning. Unsafe sanitary conditions, food and water contamination, and poor hand hygiene also contribute to disease transmission and are particularly dangerous to the very young or elderly and those with other chronic illnesses. Some of these situations are easily remedied by the individual, whereas others require more of a community-focused attention to solving the problem. Chronic illnesses. Depressed immune function can develop as a result of chronic illness or treatment for medical conditions. In addition to primary immunodeficiency, conditions that directly impair the immune system, such as HIV, many chronic conditions such as diabetes mellitus and chronic obstructive pulmonary disease, malnutrition, and cancer also lead to reductions in immune function as a secondary consequence to the disease or its treatment. Medical treatments. Medical treatments may be implemented specifically to inhibit a normal immune response or an autoimmune response, or they may lead to immunosuppression as a consequence of the treatment. For instance, in the case of tissue graft or tissue organ transplantation, Medication is administered to induce a state of immunosuppression so that the body does not mount a normal immune response and cause rejection of the graft tissue. Conversely, pharmacologic treatments for autoimmune hypersensitivity reactions such as lupus or multiple sclerosis include treatment regimens that inhibit the immune response. Immunosuppression is a common side effect of cancer treatment. The stress associated with many medical treatments, both psychological and physical, places an added burden on the immune system and may leave the individual vulnerable to illness. Genetics. As an individual's genetic base, overall health, and history of exposure to potential antigens influence immune functioning. A number of genetic diseases may lead to depressed or absent functioning of parts or all of the immune system. As a group, complement deficiencies are comparatively rare, and their prevalence varies depending on the specific deficiency and the age of the person. Another immune deficiency, common variable immunodeficiency, is one of the most prevalent primary immunodeficiency diseases, with an estimated 1 case per 30,000 people. Allergies to food or environmental stimuli and type 1 diabetes mellitus are also considered a type of immune dysfunction. The incidence of those diseases is widespread in both children and adults of all ethnic origins, with variations depending on geography and ethnicity. High-risk behaviors and substance abuse. A number of high-risk behaviors have been associated with the development of a dysfunctional immune system. Transmission of HIV and hepatitis virus may be directly related to high-risk sexual behaviors and sharing needles among IV drug users. According to Waldschmidt and colleagues, excessive alcohol consumption leads to compromised immunity, innate and acquired, dysfunction of components of the immune system, and increased risk of infection. Pregnancy. Immunity is influenced by pregnancy, creating a situation in which the mother is immunocompromised. The developing fetus exists in what has been termed a privileged immunity environment in which fetal antigens from the father do not stimulate an immune response and rejection of the graft carried by the fetus-placenta connection and the mother. The placental barrier between mother and fetus is open to communication between mother and fetal cells. It has been found that fetal cells may remain in the mother's tissues for long periods of time, creating a situation called microchimerism, or a mixing of cells of different origins. A microchimerism may also be created in the fetus, and research is investigating the role that this may play in the development of autoimmune diseases. Exaggerated immune response. Gender, race, and ethnicity. Some hypersensitivity disorders have higher incidence and prevalence by virtue of gender, race, or ethnicity. For example, SLE, or lupus, occurs more often in women than in men by a 10-to-1 ratio, and African Americans are 8 times more likely than white non-Hispanics to contract the disease. Genetics. Genetics is often responsible for the formation of an exaggerated immune response. An exaggerated reaction may be minor and serve more as an annoyance, such as seen with some environmental or food allergies, or may lead to destruction of normal tissue, loss of organ function, or death. In some cases, the genetic basis for the development of hyperimmune disorders requires that the gene or chromosome be carried by both parents, or sometimes only one, and some disorders require an environmental or physiological trigger, such as hormonal changes seen in puberty, in addition to the predisposition to a hyperimmune disorder created by genetics. Environmental or medication exposure. Environmental or medication exposure to a foreign antigen may elicit an exaggerated immune response. Foods, drugs, pollens, dust, molds, bee venom, vaccines, or serum may all evoke hypersensitivity reactions, types 1, 2, and 3, and some may evoke more than one type of hypersensitivity. Generally, these hypersensitivity reactions do not occur on first exposure to the foreign antigen, but rather on re-exposure. However, genetic predisposition, exposure by the mother during fetal development, or other contributing factors may cause an exaggerated response on first presentation of the pathogen. In many cases, individuals who manifest an allergic type of exaggerated response to one type of pathogen, such as pollen, will demonstrate a similar reaction to other antigens in the same or similar class. Medication exposure may act similarly to environmental exposure in inducing an exaggerated response. Some individuals report an allergic type of exaggerated reaction on first exposure to some medicines, such as penicillin. In some individuals, a previously expressed exaggerated immune response may be amplified further in the presence of specific medications. For example, cancer treatment that includes the use of monoclonal antibodies has triggered exaggerated hypersensitivity reactions in some patients, even though a more mild reaction to the same pathogen was experienced in the past. In your assessment of your patient, you need to take a good medical history, family history, and genetic history of any autoimmune disorders. You need to list and have all medications on your assessment, any allergies to medications or other substances such as pollen or latex, lifestyle behaviors in terms of drug and alcohol abuse, exercise, occupation, and social environment. And also nutrition should be assessed as well. Examination findings indicative of immune status are presented from the perspective of normal or optimal immune functioning, suppressed immunofunctioning, and exaggerated immune functioning. Optimal immune function, clinical indicators of optimal immune functioning reveal an individual who generally appears well and is well nourished. Vital signs are within normal parameters for age. Lymph nodes should be soft, movable, and non-tender, although lymph nodes are often not palpable among older adults. Wounds that may be present are healing within a time frame normal for the type of wound. Clinical findings: suppressed immune function. Clinical indicators of suppressed immune functioning may be mild or widespread, and they may be indicative of impending immune system failure. Vital signs may or may not be within normal parameters for age, depending on the amount of suppression and the degree to which the host is immunocompromised. The individual may not appear to be well nourished, may present with weight loss or wasting syndrome, and may complain of generalized fatigue or malaise. Impaired wound healing is present, and with sufficient immune system suppression, opportunistic infections and diseases may also be present. As a result of inflammation and infection within the central nervous system, psychological evaluation should be included because it may disclose a change in cognitive functioning or depression. The presence of seizure activity or changes in motor behavior should also be determined. Should the individual present with clinical manifestations indicating significant immunocompromise, a more thorough evaluation related to specific opportunistic infections and diseases would be appropriate. Clinical findings. A number of serious health problems develop for the immunocompromised individual. Some problems include an increase in the incidence of infection by bacteria and viruses, the development of superinfections such as MRSA, methicillin-resistant Staphylococcus aureus, or Clostridium difficile, which is C. diff, or the development of treatment-resistant fungal infections secondary to antibiotic treatment for primary bacterial infections. In situations in which a suppressed immune system is evident, the individual may not be able to mount a sufficient response to avoid or repair a diseased body, organ, or system. For example, cancer, particularly in the elderly, has been associated with an immunocompromised state and a diminished ability to recognize and destroy mutant cells. Suppressed immune functioning includes symptoms of frequent frequent infections, report of poor wound healing, fatigue, malaise, and weight loss. Clinical findings: they may appear poorly nourished or have wasting syndrome, may have chronic wounds, may have an enlarged lymph nodes, and presence of an opportunistic infection. Common diagnostic tests. Primary testing. Lab and diagnostic testing begins with basic blood tests to determine red blood cell and white blood cell counts with differential evaluation. A fluorescent antinuclear antibody test is standard in the evaluation of potential autoimmune diseases. Screening tests such as C-reactive protein and ESR, erythrocyte sedimentation rate, may also be done. CRP is used to determine inflammation in the body and not to diagnose a specific immune dysfunction. It may also be used to follow the progress of and response to treatment for diseases such as rheumatoid arthritis, lupus, and other autoimmune disorders. An ESR is useful in monitoring inflammatory or cancerous diseases, rheumatoid arthritis, and other autoimmune diseases, and tuberculosis. Allergy testing. Allergy testing is often important in diagnosis, and it may necessitate a skin test, an allergen-specific immunoglobulin IgE blood test, or both. Skin testing helps determine allergens to which the individual is sensitive, and the IgE blood test measures the amount of IgE in the blood. Higher levels are associated with a more severe allergic response. Circulating blood levels of IgM and IgA may also be measured. Advanced or disease-specific testing. More specific blood testing includes cytogenic analysis to detect chromosomal instability, indicative of chromosomal disorders, DNA analysis to detect genetic mutations, and enzyme-linked immunosorbent assay, called ELISA, E-L-I-S-A, to determine blood levels of IgG subclasses and diagnose IgG deficiency. T lymphocyte levels and proliferative response to antigen introduction testing aids in determining T cell capacity in an immune response and provides another avenue for information. Rheumatoid factor is a blood test to determine the presence of antibodies against immunoglobulins and is evaluated in combination with other blood tests on the immune system. The ELISA and confirmatory Western blot tests are done to confirm the presence of antibodies to HIV infection. The TORCH, T-O-R-C-H antibody panel searches for the presence of antibodies to cytomegalovirus, herpes simplex, rubella, and toxoplasmosis. Complement system testing is done to determine the presence of deficiencies or abnormalities in complement proteins, addressing both quality and activity of the proteins. Deficiencies contribute to increased incidence and severity of infections and autoimmune dysfunction. Tests of organ functions. Tests are often performed to aid in assessing specific organ function or to monitor the effectiveness of treatment regimens. These tests include hemoglobin A1C levels in diabetes mellitus management, hepatic function tests, and thyroid screening panels. In most cases, serial laboratory testing is recommended to assess both progression of disease and effectiveness of treatment strategies. Clinical management. The clinical management of individuals with immunosuppression or hyperimmune conditions varies widely depending on the type of condition, severity, and attribute variables such as age, health status, and underlying medical conditions. Such variables must be considered when making clinical management decisions. Primary prevention. The cornerstone of primary prevention for immune system disorders is based on recommended vaccinations across the lifespan. The CDC's Advisory Committee on Immunization Practices has established recommended vaccination schedules for children, adolescents, and adults, in addition to a catch-up schedule. Schedules and updates are easily found on the CDC website. Primary prevention also includes reduction of modifiable risk factors noted previously. This includes avoiding high-risk behaviors, minimizing exposure to environmental triggers, eating a proper diet, and engaging in regular exercise. Research has demonstrated that achieving the daily recommendation doses of vitamins and minerals contributes to a properly functioning immune system. New research is addressing the role of vitamins A and D in protecting and supporting the immune response and may serve a valuable contribution to many medical treatment regimens in addition to their usefulness in one's daily diet for health maintenance. Secondary prevention or screening. Secondary prevention focuses on screening for the presence or emergence of immune system disorders. There are a few screenings specifically directed at immune system dysfunction for the general public. However, some screenings, like HIV, are recommended for high-risk groups. Advances in genomic testing may prove useful in developing screening tests for more diseases affecting the the immune system in the future. Collaborative interventions. Collaborative treatment strategies vary depending on whether the immune dysfunction is one of deficiency or an exaggerated response. Interventions may range from supporting an inadequate immune response to diminishing the consequences of an exaggerated response. An overview of selected clinical management strategies for the treatment of immune system diseases or dysfunction is provided in Table 23.2 in Concepts on page 225. Interrelated concepts. The concepts of immunity is closely related to the concepts of inflammation and infection. There exists overlapping among the concepts in the area of pathology, laboratory and diagnostic tests, clinical manifestations, nursing interventions, and clinical outcomes. A discussion of the concepts inflammation and infection is found in Concept 24, Inflammation, and Concept 25, Infection, respectively. Tissue integrity is also closely aligned to immunity, because a deficit in tissue integrity will cause the body to invoke an immune response and may lead to both inflammation and infection. Stress has been discussed as a pathological influence that both may initiate an immune response and may lead to immune dysfunction. Stress may also lead to an alteration in glucose regulation. Resultant elevated blood glucose levels can exaggerate both inflammation and infection situations. Both inadequate nutrition and extreme or prolonged fatigue are stressors to the body, either of which may cause the individual to become immunocompromised or cause the individual to have an exaggerated pre-existing immune response. These concepts were previously discussed as methods by which an individual may become immunocompromised. Interrelationships are demonstrated in Figure 23.3. Examples of diseases that may develop with immune system diseases represent cases of B or T lymphocyte dysfunction, hypersensitivity reactions, complement dysfunction, or dysfunction of more than one component. Many examples have been introduced throughout this concept presentation. Box 23.1 provides a brief overview of some of the more common diseases that may lead to immunocompromise. When considering an immune response, it is most important to remember that the response is a complex interaction between a foreign antigen and a wide variety of differing cells, and is also dependent on genetic, environmental, and overall health parameters that are unique to each individual. The presence and progress of immune responses and the development of immunocompromise are unique to each individual and require a thorough review of health history, presenting symptoms, and laboratory and diagnostic tests when determining nursing care strategies. I'd like to go through exemplars now. Featured exemplars are Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's and non-Hodgkin's lymphoma are types of cancers that originate in the lymphatic system and represent a suppressed immune state. Non-Hodgkin's lymphoma is more common than Hodgkin's lymphoma, and it may arise from either the B cells or the T cells. Symptoms for both types of lymphoma include swollen lymph nodes in the neck, axilla, or groin, abdominal pain, persistent fatigue, fever and chills, night sweats, and weight loss. Most people diagnosed with non-Hodgkin's lymphoma have no obvious risk factors. Some factors that may increase the risk include medications that suppress the immune system, infection with selected bacteria or viruses, pesticides, or age, being older than 60. HIV disease. Infection with retrovirus HIV leads primarily to destruction of CD4 T cells, leaving the person with an immune deficiency and a diminishing ability to fight other opportunistic diseases and infections. CH4 or helper T cells are critical in the overall functioning of the immune response by signaling other cells in the immune system to perform their designated function. HIV-mediated destruction of lymph nodes and lymph organs also contributes to immune system dysfunction. Ultimately, CD4 destruction results in the development of AIDS, the third and final stage of HIV disease. Anaphylaxis is an extreme, exaggerated allergic response to foods, medication, stinging insects, and exercise. Anaphylaxis may involve a few or multiple body organs or systems, with symptoms ranging from non-life-threatening symptoms such as sneezing, hives, itching, and diarrhea to life-threatening with restriction of breathing and circulation. Symptoms can occur from minutes to hours after exposure to the allergen, with the reaction being one of three types: single reaction occurring immediately after exposure, double reaction with the first reaction minutes to hours after exposure, and a second reaction 8 to 72 hours after the first reaction, and a single long-lasting reaction that may last hours to days. Allergic rhinitis, commonly referred to as hay fever or pollen allergy, may also be associated with food allergies, atopic dermatitis, called eczema, or asthma. Allergic rhinitis is common in all age groups and in approximately 10% of children younger than 18 years. The condition is often seasonal, and symptoms typically include inflammation of the nasal passages, resulting in a runny nose, sneezing, congestion of the nose, and itchy, red, watery eyes. Hyposensitization by injection of a diluted form of the antigen may be a necessary part of the treatment regimen. Systemic lupus erythematosus. SLE, or lupus, is a chronic inflammatory autoimmune disease that affects multiple body organs and systems, including joints, skin, kidneys, blood cells, brain, heart, and lungs. The most obvious sign of SLE or lupus is a butterfly-shaped facial rash that spreads across the cheeks and bridge of the nose. This rash is present in most, but not all, cases of SLE. As an autoimmune disease with an exaggerated response, cells of the immune system begin to attack the self cells, damaging or destroying multiple organs with periods of flare or remission. There is no cure for lupus. Treatment is directed at managing symptoms. Type 1 diabetes mellitus, another autoimmune disease, typically manifests in young people, although it can occur in adults, presenting with hyperglycemia as a result of the beta cells in the pancreas either not producing or not producing enough insulin, because the immune system has attacked and destroyed the insulin-producing cells. Heredity plays a major role in determining susceptibility to beta cell destruction. The most common presenting symptoms include hyperglycemia, polydipsia, polyuria, and metabolic acidosis. If uncontrolled, chronic high blood glucose levels lead to damage to the vascular and microvascular system, peripheral neuropathy, kidney damage, and hypertension. Multiple sclerosis is a neurological disease that ranges from being relatively benign to overwhelmingly disabling as the immune system attacks the nerve-insulating myelin sheaths and disrupts communication between nerves and muscles. The first symptoms generally occur between the ages of 20 and 40 years and include a combination of blurred vision, blindness in one eye, muscle weakness, balance or coordination impairment, paresthesias, numbness or tingling, speech impediments, dizziness, or hearing loss. Over time, many people experience cognitive impairment, difficulty with concentration or memory, poor judgment, and depression. Although there is no cure, some medications are demonstrating promise in reducing the number of exacerbations and slowing the progression of the physical disability. Question: what causes in part the loss of immune effectiveness in the elderly? Shrinking of the thymus gland, increased levels of T lymphocytes, an immature immune system, or hypogammaglobulinemia? And you should have answered shrinking of the thymus gland. Next question: which cell is responsible for secreting antibodies? T lymphocytes, B lymphocytes, helper T cells, or immunoglobulin E? Next question: what is often responsible for the formation of an exaggerated immune response? Is it A, chronic illness, B, age, C, lack of immunization, or D, genetics?